You're standing in line at the grocery store. Nothing dramatic is happening. And then, out of nowhere, your heart starts pounding. Not a flutter. A pounding, like you just sprinted up a flight of stairs. Your chest feels tight. The edges of your vision go soft. The floor tilts a little. You sit down right there in the aisle. Someone asks if you're okay. You're not sure. If you have Sjogren's, this might already sound familiar. And here's the part almost nobody tells you. What you just experienced can look, on paper, on a monitor, in an ER triage note, almost identical to a heart attack. Same racing pulse. Same chest tightness. Same wave of doom. So you go to the ER. They run an EKG. They check your troponin, the blood marker for heart damage. Both come back normal. And then, more often than you'd think, you get sent home with a pamphlet on anxiety. Here's the problem with that. One study looking at emergency room palpitation cases found that a real arrhythmia was picked up in only about 1 in 10 patients, which sounds like it supports the "it's probably not your heart" story. But a different study found that 67% of patients who did have a genuine underlying heart arrhythmia were first told it was a psychiatric issue. In other words, the system is bad at telling the difference in both directions. People with nothing wrong get scared. People with something real get dismissed. Today we are going to walk through exactly why Sjogren's does this to your nervous system, why it can genuinely mimic a cardiac event, and, just as importantly, the one thing that actually can be your heart, that you should never let a doctor wave off as just dysautonomia. Let's get into it. Part 1. The hidden link between Sjogren's and your heart. If you've had Sjogren's for a while, you already know the line doctors love to open with, dry eyes and dry mouth. That's the textbook definition. That's what most general practitioners were taught in maybe one paragraph of medical school. And it is wildly incomplete. Here's a number that should be shocking, and isn't talked about nearly enough. There are an estimated 4 million Americans living with Sjogren's, and roughly 75% of them are undiagnosed. Not haven't gotten around to it, undiagnosed, actively living with a systemic autoimmune disease that no one has named yet. And here's the piece that connects directly to why you're watching this video. For a lot of patients, especially younger ones, the nervous system symptoms, the racing heart, the dizziness, the brain fog, show up before the classic dryness does. Sometimes by years. Sometimes by up to a decade. Autonomic dysfunction is more common in Sjogren's than in any other autoimmune disease we know of. So if your first Sjogren's symptom was actually your heart rate doing something strange while you were standing in the shower, you're not imagining a connection that isn't there. You're describing one of the most common, and most commonly missed, presentations of this disease. There's a researcher and patient advocate named Lauren Stiles, who founded Dysautonomia International after her own experience with Sjogren's-related dysautonomia. She describes it as a spectrum, and I think this framing is genuinely useful, so let's borrow it. At the mild end, you have the dryness itself, dry eyes, dry mouth, dry everything, which is actually already a form of autonomic dysfunction, because the nerve signal that should be telling your glands to produce moisture is being blocked. In the moderate range, you get orthostatic intolerance and POTS, the racing heart, the dizziness on standing, the thing this whole video is about. And at the severe end, you get autonomic failure, a state where the sympathetic nervous system essentially stops firing properly, and instead of your heart rate speeding up to compensate for a blood pressure drop, it just doesn't. That's actually the opposite problem from POTS, and it's more dangerous, because your body loses its ability to compensate at all. Most people watching this are somewhere in that moderate zone. And I want to tell you a quick story that a cardiologist named Dr. David Weissman shared, because it's such a clean illustration of the mistake in our title. He was doing a consult on a 21-year-old woman who had just had brain surgery to remove a benign tumor called a meningioma. The tumor didn't need to come out. It wasn't causing harm. But her doctors couldn't explain why her heart rate kept spiking, and they pinned it on the tumor, and she had surgery for it. When Dr. Weissman actually laid her down, let her rest, then had her stand up, her heart rate shot from a normal 70 up to 170 beats per minute. That's textbook POTS. Undiagnosed for who knows how long, misattributed to a brain tumor, and treated with an unnecessary surgery. That's the cost of not knowing what this is. So let's actually understand it. Before we get into part 2 cause, I have 3 more parts for you. I built something specifically for not just tracking, and doctor's appointment. It is called Sjogren's Ultimate Symptom Map and Diagnostic Action Plan, and it walks you through exactly which symptoms to track, not just for Sjogren but also for MS and RA. Drop symptom map in the comment, and I would send the link for you to access it. Let's get back to the research. Part 2. The science of autonomic dysregulation. To understand why Sjogren's does this to your heart rate, you need a very quick tour of what your autonomic nervous system actually is. Think of it as your body's autopilot. It's the system running in the background handling everything you don't consciously think about. Your heart rate, your blood pressure, your digestion, your sweating, your pupil size, your immune regulation. It has two main branches that work like a gas pedal and a brake. The sympathetic nervous system is your gas pedal, fight or flight, speed things up, get ready for action. The parasympathetic system is your brake, rest and digest, slow things down, conserve. In a healthy person, these two systems are in constant, seamless negotiation. You stand up, gravity pulls blood down into your legs, your blood vessels should tighten and your heart should give a small, brief speed up to keep blood flowing to your brain, and then it settles right back down. It's so automatic you never even notice it happening. In Sjogren's, this negotiation breaks down, and here's the actual mechanism, which is where things get interesting. Sjogren's is fundamentally an antibody disease. Your immune system, for reasons still being researched, starts producing autoantibodies, antibodies that attack your own tissue instead of a virus or bacteria. One of the most well-studied targets is something called the M3 muscarinic receptor, M3R for short. This receptor sits on your salivary glands, your tear glands, and critically for this video, it's also part of the cholinergic signaling pathway, the same chemical messenger system your vagus nerve uses to communicate with your heart. Up to 97% of Sjogren's patients, particularly early in the disease, carry antibodies that block this receptor. Picture it like this: your nerve is sending a perfectly good signal, produce saliva, or slow the heart rate down, but there's an antibody sitting on the receptor like a piece of gum jammed in a lock. The message never gets through. Your nerve fibers are completely intact. Nothing is structurally broken. But the signal can't land. Some doctors and researchers describe this as functional dysautonomia, and I want to be really clear about something. Functional does not mean fake, or psychological, or all in your head. It means your hardware is fine but your software is being actively sabotaged by your own immune system. Broader antibody panels have also found Sjogren's patients testing positive for antibodies against adrenergic receptors, the ones involved in the sympathetic, gas pedal side of the system. So the sabotage isn't limited to one signaling pathway. It can hit the brake and the gas pedal simultaneously, in different combinations for different people, which is part of why no two Sjogren's dysautonomia patients look exactly the same. There's also a structural piece to this, separate from the antibody story. Along your spinal cord, on both sides, you have clusters of nerve tissue called autonomic ganglia. Think of them as relay stations, mini processing centers that sort information before it reaches your brain or your organs. Sjogren's can directly inflame these ganglia. And here's a frustrating detail. We currently have no imaging technology and no safe biopsy method to detect this in a living patient. It's essentially invisible on every standard test, which is a huge part of why so many people get told your scans are normal while still feeling deeply unwell. Researchers at Johns Hopkins used a specialized MRI technique in one study and did find inflamed sensory ganglia that directly matched patients' pain locations, and when those patients were treated with IVIG, both the ganglia inflammation and the pain measurably improved. That's about as close to physical proof as this field currently has. I want to leave you with one more piece of ammunition here, because I know some of you have been told your racing heart is anxiety. The official 2015 Heart Rhythm Society guidelines on POTS state plainly that while anxiety is commonly present in POTS patients, detailed physiologic studies confirm the heart rate response to standing is not caused by anxiety. It is a response to a real, measurable, physiologic abnormality. Anxiety can absolutely make it worse. That's true of almost any chronic illness. But anxiety is not the engine driving your heart rate to 170. Your antibodies are. Part 3. Why your heart races, your head spins, and where the heart attack mimic actually comes from. Let's get concrete about what's actually happening in your body when you stand up. When you go from lying or sitting to standing, gravity immediately pulls somewhere between 500 and 900 milliliters of your blood down into your legs and abdomen. That's roughly 2 soda cans worth of blood, redistributed in a couple of seconds. In a healthy nervous system, Your blood vessels in the lower body reflexively tighten to push that blood back up, and your heart gives a small, temporary increase in rate to help. You never notice it. In POTS, that vessel tightening reflex is weak or delayed. Blood pools in your legs. Less blood reaches your brain and your heart's filling chambers. Your body panics, correctly, and floods you with epinephrine and norepinephrine to try to force the issue. Constrict the vessels, speed up the heart, get blood back to the brain by brute force instead of finesse. This is the exact mechanism behind why POTS can feel indistinguishable from a heart attack or a panic attack. That flood of adrenaline family hormones causes forceful or skipped heartbeats, chest tightness, shakiness, a sense of doom, because that's what those hormones do, regardless of why they were released. Your body isn't malfunctioning randomly. It's using the exact right emergency system for the wrong-sized emergency, and it's using it repeatedly, sometimes dozens of times a day. Here's the actual diagnostic line, if you want language to bring to a doctor. POTS is defined as a heart rate increase of 30 beats per minute or more in adults, 40 or more in adolescents, within the first 10 minutes of standing, without a significant blood pressure drop. Orthostatic hypertension is a different animal, a drop in systolic blood pressure of 20 points or more, or diastolic of 10 points or more, within the first 3 minutes of standing. If this is happening, POTS technically can't be diagnosed at the same time, because the primary problem is different. There's a third category that gets confused with POTS constantly, inappropriate sinus tachycardia, or IST. In IST, your resting heart rate is already above 100 beats per minute even lying down. It's not about position at all. Here's the tricky part. Someone with IST can also meet the numeric criteria for POTS on a standing test, but because the underlying resting elevation points to a different mechanism, IST is generally considered the primary diagnosis in that case. This matters because it can point your doctor toward different testing and different medication choices. And listen, if none of these labels fit you perfectly, you are not alone, and it doesn't mean nothing is wrong. A lot of patients are deeply symptomatic without cleanly checking every box on a rigid diagnostic checklist. That gray area is real, frustrating, and unfortunately common, and it's a major reason people go years without an explanation. Now, the heart attack mimic, the part of the title I promised you. I want to walk you through two specific, real scenarios that get mistaken for cardiac emergencies, because I think they're the most useful thing in this entire video. Scenario 1. The vocal cord attack. Sjogrens can affect a nerve called the recurrent laryngeal nerve, part of a broader pattern where Sjogrens can inflame cranial nerves, including the trigeminal nerve in roughly 10% of patients. When this nerve is affected, it can partially paralyze one side of your vocal cords. The result is a sudden, terrifying attack where you genuinely cannot breathe properly. People end up in the ER during these episodes, oxygen saturation checked, and it reads 100%, completely normal, which leads staff to conclude it's a panic attack, because nothing on the monitor explains the distress. One patient in the research I pulled for this video described exactly this happening to her, repeatedly, until she happened to have an attack while physically in front of an ENT doctor who scoped her throat in real time and watched her vocal cords simply not move. That's not anxiety. That's a mechanical, nerve-based breathing obstruction that looks and feels like you're suffocating, and it will not show up on a pulse oximeter. Scenario 2. Actual cardiac inflammation. This is rarer, and I want to be precise about that word, rare, not common, but it is real, and it's the reason I don't want you walking away from this video thinking, it's always just autonomic, never worry about your heart. Sjogrens can, in a minority of patients, cause genuine inflammation of the heart itself, pericarditis, inflammation of the sac surrounding the heart, and less commonly myocarditis, inflammation of the heart muscle, or even conduction abnormalities like AV block. In case reviews of Sjogren's patients with confirmed cardiac involvement, the most frequent findings were AV blocks, autoimmune myocarditis, and pericardial effusion, with patients presenting with chest pain, shortness of breath, fever, or fainting. Here's a genuinely useful differentiator for pericarditis specifically. The pain tends to be sharp, it gets worse when you lie flat, and it gets better when you sit up and lean forward. That's a distinct pattern from typical cardiac ischemic pain, and it's worth knowing, because if you already carry a dysautonomia diagnosis, there's a real risk that a new symptom like this gets automatically filed under just your POTS instead of being properly worked up. So here is the actual, practical mistake this video is named for, stated as plainly as I can. the mistake isn't picking the wrong side. It's assuming there's only one side to pick. Most racing heart, chest tight, dizzy episodes in Sjogrens are autonomic and not dangerous in the acute sense, but they are real, they deserve treatment, and they are not anxiety. And a smaller number of new cardiac symptoms genuinely do need a cardiologist's eyes on them, specifically to rule out inflammation that a routine EKG and troponin might not fully capture. You need a doctor who knows to check for both, instead of one who either panics every single time, or dismisses everything with a shrug. One more thing worth flagging quickly, because it's a legitimate medical emergency that gets missed: sudden hearing loss. Sjogren's-related inflammation can cause sudden sensorineural hearing loss, and this needs high-dose steroids fast to have the best chance of recovery. One patient in the source material for this video was dismissed by her ENT, put herself on steroids, and recovered about 90% of her hearing, but that's a gamble you shouldn't have to take. If you ever have sudden hearing loss in one ear, especially with a Sjogren's history, treat it as urgent, not wait and see. There's also a phenomenon called coat hanger pain, which is common enough in dysautonomia, showing up in an estimated 93% of people with autonomic dysfunction, that it deserves its own quick explanation. It's a dull, cramping ache across the back of the neck, shoulders, and upper back, in roughly the shape of, well, a coat hanger. The mechanism: the muscles holding your head up are working constantly against gravity, and when blood flow drops due to poor orthostatic compensation, those muscles don't get enough oxygen, and they cramp, similar to what a Charlie horse feels like in your calf. It gets worse standing, better lying down. If you've had this and never had a name for it, now you do. And finally, for some of you, the room spinning sensation might not be purely cardiovascular at all. Your inner ear constantly feeds your brain information about your body's position in space, and your autonomic nervous system uses that information to decide how hard to work to keep blood pressure stable. If that inner ear signal is off, even slightly, your nervous system can react to a false sense of movement, spiking your heart rate even when you haven't actually changed position. This is sometimes called vestibular-related dysautonomia, and it's a genuinely different mechanism from classic blood pooling POTS, even though it can feel identical from the inside. Part 4. Navigating modern diagnostic tools. Let's talk about how you actually get answers, instead of a shrug. The NASA lean test. This one was originally developed to screen astronauts for orthostatic intolerance after they came back from microgravity, and it's since become a practical, low-cost way to screen for POTS and other forms of orthostatic intolerance without needing a specialized tilt table. The protocol: lie flat for a couple of minutes to establish a calm baseline. Then stand up, heels about 6 inches from a wall, shoulder blades lightly touching it. This removes most of the help your leg muscles would normally give your circulation, which is exactly the point. Heart rate and blood pressure get measured at regular intervals, ideally every minute, for a full 10 minutes. 2 important safety notes. First, this should never be done completely alone. People with significant orthostatic intolerance are at real risk of fainting, so have someone else in the room. Second, timing matters more than most people realize. Research has found that at least 5 minutes of standing is needed to catch signs of orthostatic intolerance in most people, and the full 10 minutes catches even more. A quick 1 to 2 minute standing check in a routine doctor's visit, which is often all that happens, will miss a meaningful number of real cases. Small fiber neuropathy screening. This is a genuinely active area in 2026 research. Small fiber neuropathy commonly overlaps with dysautonomia. It can cause the orthostatic dizziness we've been talking about, alongside burning or tingling sensations. The gold standard test is a skin punch biopsy that measures the density of nerve fibers in a small skin sample. But, and this is important to say honestly, even the best available evidence puts that test sensitivity around 74 to 78%, meaning it can still miss real cases. No single test is currently sensitive or specific enough to serve as a true stand-alone gold standard. So if this test comes back normal and you're still deeply symptomatic, that doesn't mean nothing is wrong, it means the test has real limits. The seronegative trap. This is maybe the single most important thing to understand if you've been dismissed. About 40% of Sjogren's patients test negative for the SSA and SSB antibodies most doctors screen for first. And here's the cruel twist. Patients presenting primarily with neurological symptoms, dysautonomia, sensory neuropathy, are actually more likely to test negative on those antibodies, not less. So the exact group of patients most likely to have the dramatic, disruptive symptoms in this video is also the group most likely to be told your blood work is clean. It's probably not Sjogren's. That's backwards, and it's worth saying out loud. If blood work is negative or inconclusive but suspicion remains high, the next step is usually a lip biopsy, technically a minor salivary gland biopsy, which looks for characteristic clusters of immune cells around the gland tissue. One nuance almost nobody explains. This biopsy has mainly been validated in patients who are already SSA positive. It's about 80% positive in that group, but it's never been properly validated against a purely SSA negative population. In plain terms, even the confirmatory test wasn't built with a lot of you in mind, which is part of why diagnosis can take years. There's also a strange detail worth knowing if you're a current or former smoker. Nicotine stimulates the parasympathetic nervous system in a way that's been shown to skew lip biopsy results, sometimes toward false negatives, sometimes false positives. It's an obscure finding, but if you've smoked and gotten a confusing biopsy result, it may be a factor worth discussing with your doctor. One more myth worth killing here: your standard inflammation blood work, CRP, and SED rate, is often completely normal in Sjogren's, even during a real flare, because those markers don't reliably track this particular disease's activity. If a doctor tells you your inflammation markers are normal, so you're not that inflamed, that's a myth, not a fact. Sjogren's inflammation happens in a way that doesn't reliably show up on generic blood work. What's actually being researched right now? If you want a reason to feel hopeful rather than just informed, here's what's currently in motion. Researchers at Johns Hopkins are running a funded study looking specifically at autonomic and sensory ganglia biomarkers in both Sjogren's and POTS patients, essentially trying to build the diagnostic tool that currently doesn't exist. A separate study at Case Western is comparing the immune system profiles of POTS patients with and without Sjogren's, to better understand what's actually different at a cellular level. This is a genuinely active research area, not a dead end. Part 5. Practical strategies for daily stability. I want to be honest with you about something before we get into this section. None of what follows is a cure, and it doesn't work identically for everyone. But there is real, published evidence behind each of these approaches, and they're worth understanding, and worth discussing with your own care team before you start anything new. Volume and salt. Because so much of this comes down to not having enough circulating blood volume to fight gravity properly, increasing fluid and sodium intake is one of the most consistently recommended first steps. Typical guidance ranges from 3 to 10 grams of sodium a day, alongside roughly 3 liters of fluid, though this genuinely needs individualization, especially if you have any blood pressure or kidney concerns, so this is a conversation to have with your doctor, not a number to just adopt blindly. Compression. Compression garments, thigh-high stockings or abdominal binders, work by physically preventing blood from pooling in your legs and gut, helping that extra fluid volume you're working so hard to build actually reach your upper body and brain. The research shows the strongest benefit from higher pressure garments, in the 30 to 40 millimeters of mercury range, professionally fitted. I want to be upfront about something a cardiologist specifically pointed out. Real-world patient compliance with these garments is often low, because they are genuinely uncomfortable and hard to put on. If you've tried compression and given up, you're not failing, you're describing a very common experience. It's one tool, not a guaranteed fix, and it's fine if it's not the right tool for you. Exercise reconditioning, carefully. This is probably the most evidence-backed non-medication intervention, and also the one people are most afraid of, understandably, because exercise is often what triggers the crash in the first place. The key programs here, often called the Levine Protocol, the Dallas Protocol, or the CHOP Modified Protocol, all share one golden rule. The first 1 to 2 months happen entirely in a recumbent or seated position. Recumbent bike, rowing, swimming, anything that keeps you horizontal or seated, removing gravity from the equation entirely while you rebuild cardiovascular capacity. Only much later, once tolerance improves, does upright exercise get introduced. In Dr. Levine's original research, patients who completed a structured 3-month program saw real, measurable gains, improved oxygen uptake, increased cardiac mass, expanded blood volume, and 53% of participants no longer met the clinical criteria for POTS by the end. That's not a small effect. But I want to add something the standard protocols don't always say clearly enough. One patient advocate who went through this herself described starting with literally one single lap in a pool, tracking whether her breathlessness felt safe or harmful based on her prior athletic experience, and backing off completely anytime a session left her feeling worse for more than a day or two afterward. That's the real-world version of this protocol, much slower, much more personalized, and driven by your own body's feedback rather than a fixed weekly schedule. If a rigid plan doesn't fit your life, and for a lot of people, especially caregivers or parents who don't have the luxury of a guaranteed recovery day, it genuinely doesn't. That doesn't mean exercise reconditioning isn't for you. It means you may need a slower, more flexible version of it, ideally with a physical therapist who actually understands autonomic conditions. Other supportive measures. Elevating the head of your bed, actually raising the bed frame, not just using a wedge pillow, helps condition your body to the effects of gravity overnight. Physical counter maneuvers like crossing your legs, calf pumping, or squatting can help push pooled blood back toward your heart in the moment a dizzy spell starts. And if you're also dealing with symptoms that look like allergic reactions, flushing, hives, GI upset, it's worth asking your doctor about mast cell activation syndrome, which shows up frequently alongside Sjogren's related dysautonomia. Treating the underlying Sjogrens often improves those symptoms too, even though the two conditions are technically separate diagnoses. Your questions? Answered. Before we wrap up, I asked people who already live with this exact overlap what they'd still want to know after watching a video like this. Let's hit a few of the big ones quickly. How do I know if my chest pain is pericarditis versus POTS versus an actual heart attack? In the moment. Honestly, in the moment, you often can't, and that's okay. The pattern to watch for afterward: pain that's sharp, worse lying flat, better sitting forward, leans toward pericarditis. Racing heart with chest tightness that comes on specifically when you stand up, and eases when you lie down, leans toward POTS. Anything involving crushing pressure, pain radiating down your arm or jaw, or that doesn't ease with position, treat as a genuine emergency and get evaluated immediately, every time, no exceptions, regardless of your diagnosis history. If my EKG and troponin are normal, should I still push for an echocardiogram? If you're having recurring, unexplained chest pain, especially if it has that lie flat, sit forward pattern, it's a reasonable, specific thing to ask for, because pericarditis and effusion don't always show up clearly on a basic EKG. If I'm SSA/SSB negative but have every symptom, what's my next step? Ask specifically about a lip biopsy, and ask your doctor how many they've personally performed. Experience genuinely affects both comfort and accuracy of the result. Can I do the NASA lean test safely at home? With someone else present? Yes, many people do, but it's not a diagnosis on its own. Bring your results to a doctor rather than self-diagnosing from them. How do I know the difference between productive exercise discomfort and a genuine crash? The general rule from people who've done this successfully: mild, short-lived fatigue that resolves within a day is normal adaptation. Symptoms that linger 2 or more days, or that are dramatically worse than your baseline, mean you pushed too far, too fast. Does treating my Sjogrens aggressively now actually reduce my risk of the more severe stages later? We don't have large clinical trials proving this definitively yet. That's an honest gap in the research. But the consistent message from specialists in this space is that early, proactive management of dryness, inflammation, and organ involvement tends to produce better long-term outcomes than waiting until symptoms become severe. Given how much irreversible damage, like scarring in glands or corneal changes, can happen silently before you'd notice it, most specialists lean strongly toward earlier and more proactive care. If there's one thing I want you to leave this video with, it's this: your racing heart is not your imagination, and it is not automatically your imminent demise either. Most of the time, in Sjogrens, it's a real, physiologically explainable, and manageable form of autonomic dysfunction. Occasionally, it's something that genuinely does need a cardiologist's attention. The mistake isn't having symptoms that are hard to explain. The mistake is a system, sometimes a doctor, sometimes just how medicine has historically approached invisible symptoms, that only checks for one explanation instead of both. You deserve a doctor who takes both possibilities seriously. And now, hopefully, you have the language to ask for exactly that. If this helped make sense of something you've been living with for a long time, let me know in the comments, and if there's a specific piece of this you want a full, dedicated video on, tell me, because I've got a list of research a mile long that we didn't even get to today. Take care of yourselves. I'll see you in the next one.